Hi, this is Jason Goodwin. We're going to talk to you about experiencing loss today. This is coming from Chapter 13 in the Davis Advantage Basic Nursing course for first semester nursing students. I hope you enjoy it. All right, so first things first, we're going to talk about what is loss. Loss can come in many ways, not just when somebody dies, but it's any kind of undesired change, removal of a valued object, person, or situation. So that could be the loss of independence, loss of a life or a limb, loss of a family member, etc. So these are all things that not only in the patient has a direct loss, but there could be loss in the family and collaterally. So these are all things that we pay attention to. All right, so when we're talking about loss, the actual loss includes the death of a loved one, theft, deterioration, destruction. If natural disasters obviously can create a loss. A perceived loss is more internal, so that's identified by only the person that's experiencing it. Okay, so a woman might have a sexually transmitted disease and may perceive that as a loss of her innocence or something like that, right? Particularly when it's related to a sexual assault. Physical loss might be more on the injury side. So a limb amputation, loss of some sort of function like paralysis or some sort of organ change. Fourth loss is psychological, and that's more of a loss that's seen in areas of sexuality. Control is very important. If something's unjust, maybe trust could be a loss, right? These are all things that can happen to us in and out of the hospital, in and out of medical care situations. But, the loss of your youth is something that happens when you get older. Loss of your health, hope, faith, dreams. Those are all things that people are experiencing while they're in the hospital. And so that's something that we have to be cognizant of. And then there's external losses, and these are actual losses of sentimental or monetary value. Maybe, it's very common for people to go into medical bankruptcy in this country. And so that can be part of it too, right? The hospital is not, it's extremely expensive. And so that can be a source of that as well. And then environmental loss. So changes in the familiar. You used to be at home, now you're in a nursing care facility, or maybe you were in a facility, now you're in a hospital, and all the things that are associated with that. Even if it's a positive change, there can be environmental loss. An example of that is moving to a new home, but maybe you're downsizing, and so you lose a little bit of space or something like that, right? Getting a new job, there's a loss of whatever positives that you had. When you're going to college, maybe your daughter goes to college and you've lost that initial relationship. So there's always a trade-off, and those significant relationships are really important, right? So if you have a loss of a spouse, a child, a sibling, other family members, could be death, divorce, or even separation. Those are all things that affect us, right? And so however it affects us, we want to be sensitive to that when we're considering the loss for the patient. We're just getting into this. Let's talk about clicker check. So student nurse has earned A's in all of her prereqs. That's good, right? For the first exam in a new nursing course, they earn a D. Anybody ever experienced that? I'm sure you probably have. And now they feel like they might not be smart enough to become a nurse. What type of loss is the student experiencing? Is it actual, external, physical, or perceived? We'll go ahead and go through the answer here in a second. Okay, so using our test-taking strategies, we could throw out some of those, but the student's perception of themselves is not smart enough. That's internal. So that's a perceived answer, right? And so the correct answer is D. Unless they choose to share the grade with others, it cannot be seen. This is not a physical loss. So just keep that in mind with the different terminology, and go back and take a look at that in the book if you don't understand it. Okay, so loss is one thing, grief is another. So the response to loss is called grief, and it could be physical, psychological, spiritual as a response, okay? And the mourning is actually the action associated with grief. So you've heard about the stages of grieving, and mourning is part of that. Bereavement, mourning and adjustment of time following a loss. So these are all things that are associated with the loss and the process afterward, and we're going to get into those. Okay, so the theoretical foundations of grief. So there's some major theorists out there, and understand what they have done and what they've meant to the foundations of grief. Okay, Engel is one of the first ones. They believe that uncomplicated grief has a clear onset and predictable course. So that could be modified basically by the abruptness and significance of the loss and preparedness of the bereaved person. But uncomplicated grief is universal, does not require major treatment in any way. Okay, so it's just an acknowledgement of the idea. Bowlby decided that drawing on attachment theory is what's going to inform this belief, and that suggests that grief occurs when the bereaved learn that the object of their attachment is lost. Okay, so that's a little bit different in the way that the theory works, right? As opposed to Rando, who came later, and so this theory came later, and it actually it's not a person's name. It stands for a mnemonic, and it's called recognizing, which is the first one. Recognizing, so that's awareness. Reacting, right? And that is to the separation, the feeling of emotions. Recollecting, and that's things like the memories of the deceased, remembering them, reliving good times. Relinquishing the old attachment, so that would be trying to figure out new ways of living without that person or without that object. And then readjusting to the new environment. So talking about coping skills and just kind of storming again and norming, right, to get to that new place of calmness. And then reinvesting, and that's in yourself. So once the grief is somewhat stabilized, then you have the energy once again to turn toward inward, and you can try to focus outward again on trying to move on. Okay. Worden is another which describe the tasks of a grieving person and what they must achieve. So it's a standard of steps, and the progress from an initial numbness or denial. There's a spectrum all the way through experiencing and working through the pain and grief, and eventually moving on with life. Okay, a lot of these are similar strategies and theories, right? And we'll go through a couple that you've probably heard of. One of them is the Kubler-Ross, and this is 5 stages of grieving. So we've heard of this one, most of us, right? So they might not experience each of the stages in linear order, and they might even have one or even 2 more steps happening at the same time. So that's also something that can happen. The continuing bond model, which is also called the class Silverman and Nickman, bereavement is never fully resolved. It's bereavement grief. When I say those, they're sometimes interchangeable. The focus shouldn't be on individuals obtaining closure, but a way to find new ways to relate to the deceased and to the loss. Okay, your griever maintains a continuing bond, and that will never fully be resolved. And so the strategy is around developing coping mechanisms and a new value system. And then finally, Niemeyer, and that is the process of meaning reconstruction. So the best predictor of a positive adaptation to loss is the ability to find meaning in the loss. And we talked about that just a second ago, a new value system. The unsuccessful struggle to find meaning can result in complications of a form of grief. So it's very important to find meaning. Sometimes that's very difficult, right? Because some deaths are just not fair, right? And don't have much meaning. But yeah. So the factors affecting grief, number one is going to be the significance of the loss. The meaning of the person has attached to the person or the object. is going to be different for every person. The more attachment to the relationship or the object, the more difficult the grieving. That makes sense. The support systems are also super critical in the way this plays out, right? So the amount of support for the bereaved is important, which is why we're always asking about family members and things like that. People that are more emotional or that have a lot of emotional support or psychosocial support typically have better outcomes with grief, less complications. Unresolved conflict, that's a conflict existing at the time of death, unsaid words, some sort of estrangement. Those are all things that make it very difficult and can prolong the grief. And finally, circumstances of the loss. Like I said before, some circumstances are just really hard to tolerate, right? Their life can be seemingly a roll of the dice sometimes, and you see bad things happen to good people, and especially when they're with those you love, that's a hard thing to swallow sometimes. So if they feel like maybe being guilty or understanding that maybe they could have prevented something, right? I have a friend who had been married to her husband a long time, and he went out one morning to help a friend move, and he was hit behind by a drunk driver and was killed. And there might be, as an example, an unresolved feeling of grief for her, maybe because she wishes she had asked him to wait for a moment, right? And so those are the types of things that we're talking about here. Okay, other things to talk about affecting grief: previous or multiple losses. Some people have a really horrible past of these things happening to them, right? Too many deaths in their family, maybe an early death of a parent. The grieving process is much more complicated in those situations, and we have to be aware of that and help them work through that. Spirituality and religious beliefs can help us and sometimes hinder us with the grieving process. Most cultures have some sort of a ritual. In many cases, that's a funeral, right? Or what do you call that? Celebration of life, or those types of things. And that helps the bereaved begin the grieving process, and they can openly express their pain and things like that. Sometimes cultures might discourage that and encourage keeping those things close to the vest and limiting expressions to grief until it's private or maybe not at all. The timeliness of death, somebody that dies at 95 and expresses to you before they go that they've had a full life and they're ready to go, that's a very different scenario from someone who is 30 and has cancer, or the death of a child, or somebody that's in a car accident, right? So these are all things that affect their age is a big part of psychologically how we deal with that, and sometimes it can be the source of stress. So we're much more likely to accept some of those things when they're more expected. This can raise a sense of unfairness and feel like it's unjust. Depending on whether you're a religious person or not, you might ask God why this happened, right? And so those are the types of things that could be part of this. So we're aware of that, and we understand it as professionals. And so you might hear someone ask, why was their life cut short? Or they had so much going for them, God didn't give them a chance. Those are the types of things that you might hear from family members when they're angry. And then finally, it's important to understand as caregivers the developmental stage of the bereaved. So development is also an important factor, and it relates to the healthy development of life stages. So in turn, the person's stage of development can affect the grieving process. So does a child receive a death very differently from someone who's 50 years old? Of course, because their experience is different. If there's a different developmental stage, for instance, in somebody with a developmental delay, of course, that's going to be different for them to get their head around, right? So it makes sense. Okay, so the types of grief. Number one, uncomplicated. This is normal, right? Normal grief. That's a natural process to the loss, and the bereaved person is going, it doesn't mean it's easy. They're going to experience lots of feelings and behaviors and cognitions in response to that loss. And the emotions are intense, but gradually over time they diminish. But that could be several months or several years. Some emotions will always be present, but the intensity will change, right? They say it's like it's in a rearview mirror, but you can always see it. It just gets farther away. Sometimes there's dysfunctional or complicated grief, and this can be, it's described as that because it's distinguished from regular grief by the length of time and the intensity of what you feel related to that, right? So the person's response might be maladaptive, it might be prolonged or overwhelming or dysfunctional. It results when the grieving process has been interrupted or impeded for some reason. So the person gets stuck in the grieving process. Chronic complicated grief begins as normal grief, but continues long term with little resolution and an inability to rejoin life. Masked occurs when the person is grieving but expressing the grief through feelings and other types of behavior. So we'll get into some of those things. And then delayed is a grief that's put off until a later time. So you can probably imagine people in your life that have experienced grief and have fell into one of these different categories, right? Delayed is a very common grief, right? We've probably all experienced someone who has delayed, or maybe they go right back to work and they say, that's what I need to do. That's, that might be a source of delaying that. Not necessarily a problem, but it could turn into complicated grief and lengthen the process. Masked, the first thing that comes to mind with me with Masked is if you've ever watched the show Hoarders, a lot of times what I've noticed is that when somebody goes into this behavior, it's often at the loss of a spouse or maybe a career. And so this takes them into this behavior. So it's interesting how that could be probably attributed to grief in some way. Disenfranchised grief is a type of grief that's experienced when your loss is not supported socially or acknowledged by usual rites or ceremonies, okay? So it might be experienced by, for instance, let's say you have a foster kid and somehow let's say you adopted a child and then later on the biological mother comes back. I've heard of these circumstances where that can happen, and then maybe contrary to what you want, that child goes back with their mother, right? So that could be something like that. Or even maybe like somebody who is a mistress and their lover dies, right? But they're not, or even an ex-husband, they're not legitimized in the process, right? I had a friend who was remarried, and I couldn't help but notice that in his funeral, his ex-wife wasn't mentioned at all, and I just thought that was really a sad thing that was completely cut out of the story, right? So anticipatory grief is experienced before a loss occurs. So sometimes you know that somebody's going to die, and that can start early, right? You know that there's a negative outcome coming, and you can even start to detach from that person because it feels like it's going to help make it more palatable. But that ultimately leaves a person who's dying or the loss without any kind of support during that period, and doesn't necessarily ultimately help the person that is grieving. All right, another clicker check. A young woman's fiance died in a car accident, and 1 month prior to their wedding day. Since the death, she's become sexually promiscuous. What type of grief, if any, is the woman displaying? So we went through all these different types, okay? Chronic, disenfranchised, masked, or no grief. Well, there's definitely some grief going on there, I would say. Chronic, disenfranchised, or masked. So is the young woman's place in the husband's or fiance's life delegitimized? I don't think so. They have a formal relationship. So that leaves us with masked or chronic. Well, what you remember from what we talked about is sometimes the masking can evidence itself by maladaptive behavior, right? So she's expressing her grief through maladaptive behavior to mask her grief. And so that's because she's in the grieving process. So we can help her through that in a multitude of ways. It's going to differ based on tons of things, but this isn't an example that translates easily to the hospital. But if you can imagine a situation like, for instance, a family member has began drinking a lot when a husband is dying of cancer. Well, those are the types of things that could present themselves as needed in the hospital, maybe a referral to a 12-step program or some kind of professional help. Okay, how do we define death? So death is a pretty fixed idea. It's important that it is, of course, because there's a lot of legal aspects to it as well. But the higher brain death is what we call when the brainstem is still functioning, and both respiratory and cardiac activity may continue, not always, even though the person doesn't make any kind of purposeful responses to external stimuli. Okay, so some of the reflexes might still be or some of the reflexes might be absent. Some of them still might be occurring, and the EEG shows no activity, right? So you've heard of these stories where somebody is on, they might call it like, I don't even know if this is appropriate anymore, but they might call it someone being a vegetable, right? So they have no cognitive abilities. And the family, I just had a situation like this the other day. A young man was hit by a vehicle at a high speed, and I don't know, and I'm not going to presume to make a comment as a caregiver on his prognosis or capability, but the GCS was 3, and the young man was 30, and I think is going to have a very difficult time overcoming some of the things with some of the brain damage that had occurred in the hypoxia. But the family is still very hopeful, of course, and we're not going to get in the way of that. But that presents a bioethical dilemma very commonly. So there's something called the Uniform Law Commission, and they've redefined death. And so they've defined it as irreversible cessation of all functioning of the brain, including the brainstem. Okay. And so this definition doesn't provide clear guidance to states, but it's important that it created very clear guidelines for the medical standards. And so also the Uniform Determination of Death Act, which was adopted in 1981, clarifies this as well, and it includes irreversible cessation of circulation and respiratory functions. Okay, providers use several methods to assess the functioning of the brainstem, but for instance, if the pupils are fixed and unresponsive to light, if there's no corneal reflex, if there's no cranial nerve response or vestibular ocular reflexes, these are all things that we use to determine that there's a certain level of brain dysfunction. Coma and persistent vegetative state. I guess it is appropriate to say that. So a coma, let's talk about that. A coma is a prolonged, deep state of unconsciousness. It's not a sleep. It may last days or years. And the patient can't be aroused and may not have any or may have very little brainstem reflexes. Okay, so the loss of the higher cerebral functioning can create what we call a persistent vegetative state. And that's a little different from the coma, right? Because this person is not able to respond to stimuli, is unaware of the environment, and has no cognition or effective mental functions. All right. So these are different because the coma is more of a general description of the state, which may include some of the characteristics of the persistent vegetative state, but the persistent vegetative state is more of a permanent state of being, right? And that might be something similar to what I was describing in the young man I referred to earlier. Okay, so the stages of dying, this is on a physiologic basis. So prior to dying, and these are general statements, okay? Of course, this is not always going to be the case, but when you have the privilege, and it's not an easy situation, but as a caregiver, it is a privilege to be the person that is able to comfort someone when they're close to death. Some of the most interesting parts of my career have been when interacting with someone that's close to death. The communication that you get, the emotion, the insight, and the dignity and humanity that you get from being that person, it'll never leave you. You'll feel it. So 1 to 3 months prior to death, the dying person may begin to withdraw from the world. Sleep increases, and I went through this with my wife's grandmother. She started sleeping more. It became a little bit harder for her to digest food. She stopped eating things like meats, and appetite decrease. Things like meats are more difficult, and her appetite decreased. Liquids are easier to tolerate. Anorexia may be something that is occurring, and that might actually be protective, because the resulting ketosis can help diminish pain and increase the person's sense of well-being in some ways. Also, when you're burning that fat as a fuel, that can actually help a response of certain, like for instance, if somebody has diabetes, that might actually put them back into a place of better functioning depending on how much weight they lose, right? So it's possible. And that might actually result in some improvement periodically. About 1 to 2 weeks prior to death, though, a host of physical changes will start to change, and that'll indicate that the body is losing its ability to compensate and maintain itself. And then days and hours prior, and this is obviously not fixed, it's highly flexible. It's very difficult to tell at the end of life when it's going to occur, but you can often look back and see this. There might even be a surge of energy that might bring back some mental clarity. And it almost seems like there's a supernatural effect of clarity all of a sudden, right before death. Grandma came back and she told us so many things, and then she died, right? And that's a common thing that you hear. They might want to eat, they might want to talk with family members, but the patients tend to become dehydrated and have difficulty swallowing, and maybe decreased blood volume. And so at the final hours of life, what you're going to see is liver failure, oftentimes precipitated by the medications they're on, or just from organic dysfunction. They might become restless and agitated. This response can increase like cerebral hypoxia, renal failure, stool impaction, right, bowel obstructions. And so at the end of the time of death, some people unexpectedly become more coherent and energized, but then afterwards become less communicative, quiet, withdrawn, and fatigued. And then moments prior to the death, the dying person doesn't really respond to touch and can't be awakened sometimes. Typically, there's a short series of long-spaced breaths. Those are sometimes called Cheyne-Stokes respirations with pausing. There might be referred to as the death rattle. What it means is that there's a distinct change in their breathing immediately before dying. And that's a normal part of physiology. Sometimes there's medications given to help keep the patient comfortable, and also in some cases even help the family support it. Okay, so end-of-life care. We often talk about hospice care. We talk about palliative care. It's important we understand the difference between both, okay? So when we go through these two different ideas, palliative care is it's holistic comfort care, right? You've heard that. It's aggressively planned, okay? And so it's an end-of-life planning process and it supports the families and caregivers. It ensures the continuity of the care. It ensures that there's dignity and respect for the person, that there's an informed consent around what is happening and what the family and or patient is planning. Then there's, of course, an attention to emotional and spiritual concerns because of what's happening. We try to support function and survival for the duration. Okay, so what we're doing is we're managing symptoms, but not necessarily trying to prevent the disease anymore, right? So we're managing pain, we're managing depression, even dyspnea, because we want them to be comfortable, but we're not necessarily going to be giving them their cancer medication anymore, right? And you might see the family member come in and give them In-N-Out burger, and they've had a couple heart procedures, and it's like, okay, we're not going to prevent anything now, and we understand that we're going to change our plan of care to be a little bit more focused on the comfort of the end of life. That's it's slightly different than hospice care, okay? Because hospice care can look similar, but it's the holistic care of the dying client. So it's usually based on a couple premises. Number one, the quality of life is important as the length of life, okay? And number two, those who are terminally ill should face death with dignity, surrounded by the comfort of their home and family. And hospice providers really are amazing, and they're given the space to consider family members as a part of their client role. So they might, be working with the family more than the patient to help them process the situation. And a lot of times you'll hear physicians talk about within the last 6 months of life, hospice care is qualified. Okay. And that might, the cool thing about that is that might come with, once that designation is put in place by the medical provider, it opens up opportunities for increased resources so that they can be well taken care of at the end of their life. For instance, somebody that needs a large amount of narcotics at the end of their life, they're not going to have the usual bureaucratic barriers that someone else would, right? And that's good. That makes sense. Okay, so legal and ethical considerations. So advanced directives, this is, of course, important at the end of life. There's a group of instructions that we obtain, and it's called advanced directives. It can be written or oral, and it states a person's wishes about their health care. And so, for instance, if I'm incapacitated or unable to make decisions, who is going to make those decisions for me, right? And so there's also something called the power of attorney, but that doesn't necessarily give the other person the right to make the healthcare decisions for the patient. Only a durable power of attorney for healthcare can do that, okay? And that's what this is. Advanced directives is more of a general term to describe all of what we're going to talk about here. So you want a durable power of attorney for healthcare. There's also a status called do not resuscitate, okay? And then A and D, it's called allow natural death. This is not as frequently used, but the DNR, something you'll hear, it's not attempting resuscitation, okay, in the event of cardiac or respiratory failure. There are some circumstances, these all have to be highly organized and documented, where those wishes will not be honored, but only under certain circumstances, like, for instance, they might suspend it for a surgery. But in general, it's a very important thing to know because your patient has a wish that you have to potentially honor. So when you say the patient is a DNR, that's an important note for you to make because there might be a day where a code happens and you have to know whether their wish is to be revived, right? The American Nurses Association have a term, it's called medical aid in dying. And so they acknowledge in certain states that it allows a competent adult with a terminal illness to self-administer oral or other medications that can hasten death. So in some states, it allows, it's called medical euthanasia, right? And so we'll get into that in the next slide, but that's something that is out there in certain states, and it can be a very complicated bioethical process. Palliative sedation, some advocates of this, they create the use of continuous sedation until death as an alternative for assisted suicide. So the Hospice and Palliative Nurses Association, they promote this, and they control it and monitor it using sedatives, and they induce unconsciousness and ultimately relieve suffering by creating respiratory failure intentionally. And the goal is to manage intractable systems, and that's different from aiding in death in that slight way. Okay, so assisted suicide. So this is something where it means making available that the patient can end their own life pharmaceutically or even with weapons. The patient's physically capable of ending their own life, and they've expressed the intention to do so. And they only turn to the healthcare provider to provide the means, okay? So there are a few states where the physician-assisted suicide is legal, but in general, the professional organizations oppose it because it's against their oath, right? So it's not consistent with the commitments of the nursing profession and violates the public trust. Euthanasia is the deliberate ending of a life, and that's someone suffering from a terminal or incurable illness. So that would happen via active euthanasia. That would occur as a direct action of, like, for instance, an overdose of medication. Passive euthanasia would just be a result of lack of action, right? So withholding some sort of medication or food that's necessary to sustain life. And then autopsy and organ donation. Autopsy is a medical examination of the body after death to determine what the cause of death may be. And they can also do tissue samples, remove organs to potentially even harvest them. And so we do these. We don't do this in every death, but we do them to determine what the disease process was, what the causes were. It requires signed permission from the family. And there are some cases where the law enforcement community requires it, and that might be part of an investigation. And organ donation is something that once that's determined, it's pretty interesting because you'll see it's a whole process, right? And so if you have an organ harvesting and you have one in your career, you'll call a number and there will be a dedicated team that will, in some cases, fly in, harvest this organ, and then keep it alive until a donor can be available. Usually they've already located the donor, and that might even happen in the same hospital potentially. And the opposite is when a living family member might try to donate an organ, right? So very interesting process. Okay, so the assessment of a terminally ill client and family member. So a couple things about this. When the client and family are ready, you want to encourage them to talk about the client's wishes for end of life, whether it's burial or cremation or anything like that. You can always talk about those things. We're not funeral directors, but we definitely play a part in getting them to understand and maybe start to look at what some of the coping mechanisms may need to be and what the next steps may need to be to help them to get through some of those grieving processes. We can determine whether, we certainly want to determine whether they have a living will or advance directives, discuss with the client and the family organ donation or any other kind of appropriate situations. And you'll do this more commonly when you're in the emergency room, and it's a hard thing to do. But depression or grief is very common, and they also have several symptoms in common. Sadness, insomnia, poor appetite, all those things, but they're not the same, right? And so, for instance, grief and even depression, that can be a temporary thing. Depression doesn't necessarily mean clinical depression, right? Clinical depression is more of a physiologic state and a very complicated diagnosis. Depression could also mean I'm depressed because of permanent or temporary circumstances that have me right in the middle of a depression because of my grief. And that can be resolvable, but sometimes it can be confused with clinical depression. All right, so most grief is normal and not dysfunctional. And you can view that loss as the problem or the etiology, right? So Uh, Loss and grieving as the problem and loss and grieving as the etiology. That occurs when creating problems in other areas of the patient or family function. So, for instance, because of the loss, there might be a situational chronic low self-esteem related to the inability to change the event, or related to the dying while having unfinished business, right? So when a client is diagnosed as terminally ill, either you're taking care of them directly or the family is involved. This could relate on either case to anxiety, which would be related to the inability to cope or related to the unknown, the loss of control. These are all very profound experiences in life. And you'll see that people that are older, even before death, when they start to lose independence, that's a huge change for people, and oftentimes a huge source of grief. So you have to understand that and be sensitive to that. Sometimes there's decisional conflict. Maybe the family member has an opinion that differs from what the patient does, or maybe family members are in conflict about the decisions about mom, right? And so those are all things that are present in this complicated situation. And then you add into those things like fatigue, because of, obviously a lot of times people are stressed and overworked related to that, and there's exhausted their resources. And then there's the spiritual distress. Some people say that they feel like God has left them or something like that, and that might be something that they work through. All right, so what do we do as nurses as far as planning outcomes and evaluation and interventions and implementation, right? This is what we do. This is our process. So our outcomes are all based around grief resolution. And so trying to resolve that feeling about the loss. And we're not going to be able to fix that in the hospital, but we can start the process. We can help the patient identify coping mechanisms and progress through the stages of grief and help them understand what those are, express positive expectations about the future, and also seek for social support. And you'll develop your own skills as you go out there. But some interventions that we can help with, we're going to provide emotional support through the stages. We're going to encourage discussions about the previous loss and how it affects this loss, if necessary. We can talk about including significant others in the decisions. We can listen and help them express their grief. That's a very important way to do it, particularly at the end of life. Support groups can be helpful, and oftentimes we can help refer them. Crisis intervention, same as before, we can help with that as well. And it's important as a nurse that you understand how to refer someone in that circumstance. Oftentimes we make it pretty easy in the hospital, which it would be a referral to social work or the chaplain, things like that. And then spiritual support, like I said, with the chaplain or whatever way they see, by honoring their wishes or involving someone in the professional arena. Okay, so what can you do to be in therapeutic communication with a patient in this situation? Well, first of all, listen well, okay? It's not a time for you to be more interested in talking, so perfect your listening skills. Encourage and accept those expressions of feelings. You're there to receive the information, and sometimes it's okay to reassure them that it's not wrong to feel the way they're feeling, right? Anger, relief, these are unacceptable feelings. That's not necessarily the case. It's probably a good thing to let those things come, and so that you can process what you're going to do about it, right? And there's going to be a lot of stressful situations. You can observe the nonverbal cues, and you can also pay attention to your own, right? So eye contact's important. Touch, if it's appropriate, if they're comfortable with that, can be very useful. You're going to want to increase your self-awareness. So just like I said, it's not a time for you to talk as much as for you to listen, and pay attention to the things that you could be unintentionally sharing with the family that aren't helpful. And then even in a case of a coma, for instance, the other day when I was examining this young man I told you about earlier, I was talking to him the whole time, and it doesn't matter whether he understands. I don't personally know, right? I don't presume to know what is happening from a medical or supernatural perspective. So I was talking to him like he did understand me because he's a person, and if he is able to hear or listen to that, or it has any positive effect on him, I'm gonna treat him like just like I would have treated him before the accident. All right, so the facilitation of grief, it's going to involve expressing feelings. And so that means encouraging questions and responding to those questions uh, proactively, right? Within a reasonable period of time. You might sit at the head of the bed and you don't, this isn't a time for you to be typing on the computer, right? Or feeling rushed. When you observe the patient or the family member expressing feelings, um, you can encourage them to continue. Just leave it open ended. It can be non-verbally, it can be verbally, anything that they want, right? And that might include a wide range, a spectrum of feelings, anger, fear, loneliness. And we'll get into a little bit about anger in a little bit because that gets into healthcare violence, and that's something that is something we want to understand as well. Um, a good question to ask is, how can I help? What would what can I do for you? What do you need? These are all things that are non-threatening and most likely needed. So on the healthcare team, it's important that you always understand who's on the team and that everybody understands the information and following the care plan so that we don't get confused about what's happening because that can just add additional stress to the situation. And then it's a good measure is to also ask yourself, like, what would you do if you were a family member and put yourself in that place? But you don't want to compare another person's loss to your own experience. For example, um, I know how you feel because of my own mom or whatever. That can sometimes, for some people, feel like you're minimizing their own experience, even if you're trying to be consoling. So just stick to things like, tell me about how you feel. Like I said, it's not really a time for us to share our information unless it's elicited. Okay. Recalling memories. One time I had a situation where I went through a photo album with a family member, and I was able to uh, let them take me through some of their past, right? And so there might be objects of sentiment in the room. There might be signs and stuff, and it's all really cool, and you can participate in that as the nurse in being supportive of that. They might even bring in for things for you. And I've heard of nurses that bringing special things to the family member after they've spent time with them. And by all means, that's all great stuff for you to, connect with them as a person in this time of need. Finding meaning. So reviewing your life is a technique that can help patients or family members acknowledge the unique contributions, and even before they've died, right? A really good example of that is when I was in the military, I used to refer to all of our retirees by their rank. And what that did was, I would come in the room and I would talk to an old Marine sergeant, and that it was 50 years ago they were in the Marines and were a sergeant, but just like they say, once a Marine, always a Marine. And so I would come in and I would call them sergeant, and they would love it because I was acknowledging their contribution, regardless of how long it was ago, and it helped them reminisce on one of the more positive experiences in their lives, a sense of accomplishment. So it's a great way to do it. If somebody's a doctor, you could use that, say doctor, and call them that. It's just rapport, right, and respect. So finding meaning. Another way to do that is bibliotherapy is a counseling technique used for grief therapy. And so what it is it's using reading to increase a client's awareness and understanding. So poems or novels or essays, things like that, self-help literature can help them produce new insights. For instance, if you're dying and there's a book that you've been meaning to read and you want to do that, that can help you cope with the situation, right? Or even a book on how to deal with death. Maybe they want to read that, and that's helpful in this time of need as well. Or maybe a Bible. Okay, so each of these items here, this refers to this is more of like a discussion oriented slide, but you're going to have the family help with care if they can. You're always going to encourage questions, provide follow-up and referrals, just to summarize, and encourage any kind of visits with chapel or clergy or any spiritual needs. Provide anticipatory guidance. So that means anticipate what their needs are and try to help with that, and then acknowledge their feelings. It's pretty simple. Other things, though, that you can do in more of an advanced fashion is explore their coping mechanisms, and that comes through questions about how they're dealing with things or what their resources are. You can help family members and other significant others take care of themselves, and also even resolve conflict by helping them understand the situation, right? Teaching them what to expect and provide reassurance. A lot of times there's misunderstandings in the medical side of care between family members, and that can cause conflict. So you can help clear those things up when they come up. And when it finally gets to the moment of death, that's not a time for us to insert ourselves. That's a time for us to be seen and not heard, or a fly on the wall, close enough to intervene and help, but not close enough to make it about us in any way, right? So just keep that in mind. All right, so a 55-year-old patient was just informed that they have metastatic pancreatic cancer and have 4 months to live. That's rough. After a provider leaves, they say to you, I don't want my family to know, but they have to know. Please don't tell them. Please tell me what to do. Help me. What's your best response? So the ability to deal with this question, we're going to apply the thinking, doing, caring model, okay? So the ability to engage in safe and effective nursing care requires an understanding of the process and some of the therapeutic interventions to handle loss, grief, and dying. So we're going to go through that. So number one, thinking. That's our ability to listen to what is not being said, okay? Signs of anxiety, shock, stuff like that. The patient's experiencing a ton of emotions, that's clear, and may even seem like a flight of ideas, right? Your answer should consider how to provide the correct choice that incorporates that, all right? And then in doing, answer choice A could minimize the situation and close the communication. Would you say, I know this is difficult, take time to think about it. That's sort of like saying, good luck to you, right? Similarly, choice B doesn't really address the immediate need, and it might create a barrier to reaching out, right? So there's sort of, you can hold the patient's hand, but if you told them you should get a second opinion before you alarm your family, that's sort of like what, telling them advice on what they should do. And then C comes, and that might convey caring and, saying that, but holding a person's hand may not be their preferred way of dealing with that situation, right? And then finally, tell me how you're feeling right now. So this is under the idea that answer choice D is a best choice for this scenario because it's more focusing on what the client expresses, right? And their feelings can provide you insight into how to best care for them. So this choice is combined, of course, with other effective caregiving, but this is the best choice for these. All right, so when you're caring for a dying person, you're going to look at this from several different ways, right? We're going to look at it from a physiologic point of view. And so during this time, we're thinking about things like mobility or oxygenation, safety, nutrition, fluids, elimination, hygiene, pain, nausea and vomiting, right? All of those things, more physiologic in nature. Then there's going to be the psychological aspect, right? And you're not really, this isn't going to be a cut and dried situation. Most patients want to know about what's happening as soon as possible so that they can get their personal affairs in order and share their feelings with family members and come to terms with life and death. But you need to follow that based on their direction. And we're not the ones to communicate a lot of these things directly to family or even to the patient. Many times that's a physician practice, but you'll learn that as you go along once you get into the hospital or your other area. So addressing the spiritual needs, somebody might be looking for forgiveness, right? Maybe they need to go to confession, or maybe they are now all of a sudden have an epiphany that they want to be involved in a religious experience. They might ask for somebody to be praying. They might want music or meditation, right? Or spiritual readings as they go along into this. And we can support that. So you just follow that and keep that in mind. Some cultures, in addressing cultural needs, some cultures keep emotions more subdued and limit expressions to grief to private settings. So it's important that you understand some of the differences between cultural backgrounds. And this isn't something that we assume, but we can have an initial picture of what's happening, and then we ask questions to get into confirming or denying whether those things are occurring, right? Okay, so another clicker check. The client's dying of cancer and can no longer swallow. The son states to the nurse, "You must give dad some water. He has always drank a lot of water." The nurse's best response is, number one, "You sound very upset. Tell me more about your dad." Number two, "Your father is dying from cancer and water will not stop this process." Three, research shows that withholding oral fluids decreases edema. Or D, "I will call the provider and get a prescription to insert a nasogastric tube for the water." Okay, so three of these are very clinically oriented, right? And so we're going to choose the answer A. And that's because we're starting to try to, in the end of life, you're always thinking therapeutic conversations, right? And you want to, it's not about the water, right? And so options B and C close the communication and doesn't really connect in a caring way. And then option D is actually not really going to address the underlying concern. So A is, okay, sounds like there's a lot going on. Why don't you tell me more about it, right? And that's the only thing that's really going to get past that, because there's either a loss of control or fear that's driving some of those behaviors anyway. Care of the body. So when somebody dies, you're going to provide postmortem care. Some of us, in my experience, some of our students have already done it during their first semester. So this is mostly going to be a facility-specific process, but it'll include the care of the patient's body after death, any legal requirements, which can be extensive and also very prescriptive. So you have to be, it's not something you want to do without help if you haven't done it. You're going to have to arrange transportation or the morgue or funeral home, determining the disposition of the patient's belongings, arranging some of the family arrangements. So yeah, it's not an easy situation, but you will at some point probably be involved with that. So after the death, you can provide a lot of things to the family. So education is a really important part of what we're going to do during this. So the grieving person's probably fatigued, may not be sleeping, they might be disoriented. So it might not be the best time to educate them, but if it is a good time, you can reassure the person that these responses are expected and there's no right way to grieve or wrong way. So the process is going to take time and these symptoms will not last forever. But those are all things you can say when it feels like it's appropriate and you have rapport, right? When you're trying to help children deal with loss, some families may need information about how to do that for their children. And so you can potentially provide that. That's more of a specialty situation, and social work can be helpful with this. When there's a death, you need to explain to children that to explain to family members that children perceive death differently than other people. So that's not necessarily something that we have a lot of training in, so we can help acknowledge that and pass that on. And as far as loss of a patient, it's normal for you as a caregiver to feel grief when a client dies. So don't hesitate to take care of yourself. This is something that I see all the time that we just don't do a good job of. It's okay to make allowances for yourself so that you can, put your own oxygen mask on before you take care of somebody else, right? So that, as they say on the airplane. So just keep that in mind. You have a right to do that, and you should assert that right as a professional to take care of your professional ability. The other thing too is with healthcare violence, um, follow your specific facilities processes, and there's often a lot of training around it. It takes a lot of skill to de-escalate these situations, and nobody wants to be injured on the job or life threatened based on these types of things. So take that seriously when it's time. And then finally, we're going to do a Socratic reasoning question. So Bob and Kim were walking with their 5-year-old twins when a driver lost control of his car and hit them. Both girls were rushed to the hospital, where one was pronounced dead on arrival. Horrible. The other twin suffered several broken bones and was listed in stable condition. She keeps asking for her sister. What factors should be considered in the scenario, and discuss how you would provide care to the family? Man, so this is a rough one. I mean, this is going to be around concepts of loss and grief, and then even developmental stages and circumstances around death, right? So I guess the things to understand about that is that this scenario involves an actual loss, right? The unexpected removal of the person. It's going to include lots of grief, physical, psychological, and spiritual, as they're talking about here. And this is all a normal occurrence. So you're going to consider the circumstances around the death, which is an unexpected, violent accident. That's going to have normal grieving. It's going to transform that into very serious complications sometimes, right? So it's going to be a very difficult time for all involved, including the parents, and especially with the twin, right? That's a situation. So at 5 years, the daughter understands that death is permanent, but there's not a whole lot of understanding or experience about what that means long term. So there's going to need to be a healthy post-traumatic environment, including maybe therapy to help get through that process so that they don't get stuck in it. As far as interventions, it's going to be important for the parents to understand the concept of grief and how to apply that to their child and understand what the resources are. Okay, that's a big part of it. And they're going to need, in many cases, as a professional, we can give them permission to express their feelings, and that can help them process through their grief. So we can always provide referrals and therapeutic support. And then as far as an environment that's conducive to this conversation and these expressions, we can be a big part of that too. And we don't have to say anything, as opposed to we don't have to find the right words. We just can be there and truly connect with the family and experience their loss with them, without them feeling like we're a burden. But sometimes the best thing for you to do is to remove yourself so that the family can experience that on their own. Particularly with something like this, with a sibling loss, very difficult, right? So these are soft skills that we develop over time, and rapport that's going to be important with our patients helps us through these. And so I hope you've enjoyed exploring loss and grief, and I hope that you can take this with you in your practice. Thanks a lot.